Thank you, Ingrid. I'll say to begin with, I was given 20 minutes, and so I'm going to cover a few areas that I think will be relevant, but it's by no means exhaustive. And the other thing is it's no means specific and tailored to each of your children. They're general suggestions, and I think it's important to have an understanding of what normal sleep is to also then understand what problems are. And I think the other thing is that sometimes when you have children with significant developmental disabilities, you get so burdened down with all the day-to-day medical things, and sometimes the sleep you just take for granted. You think this is the way it's always going to be, and in some cases it is extremely problematic, but sometimes there are things we can do to improve it. And so I'd like to highlight a few areas that may be relevant to your families and your children. And I don't need to tell you guys, sleep is incredibly important, not just for the functioning of your child, but the functioning of your whole family. It's shown that insufficient sleep in children is related to lots of difficulties with behavioural disturbances, exacerbation of certain behaviours, problems with learning, concentration, attention, problems with mood regulation, low frustration tolerance, increasing outbursts, frustration, and poor emotional regulation. And there's certainly increasing data out there now looking at insufficient sleep also being related to obesity. And in the family, I think there's significant, the physical burden, the emotional burden of being up and being constantly sleep deprived, as well as the disruption to your employment, access to respite care, and just the quality of life and your family functioning. It has huge ramifications. And I've been doing this since '84, and I remember coming back from the States in the early 90s and people saying, sleep, why would you bother with sleep? And as time's gone on, people understand sleep is just crucial, and now you can't almost pick up a medical journal without sleep being mentioned. It's taken a long time. The problem is immense. When you look at typically developing children, about 20 to 30% of families will complain of significant problems. When you look at children with significant developmental disabilities, that number jumps up to 40 to 80%. And Ingrid will present some work looking at a study one of our medical students did, looking at the prevalence in Dravet, and it's about 70% of families will have significant problems. And the way I want to talk is to perhaps break it down into insufficient sleep. So looking at those problems that lead to difficulties falling asleep and nighttime wakings, and then move on to some more typically developing sleep phenomena such as night terrors and sleepwalking and confusional arousals, because sometimes we get so bogged down in the medical problems we forget that sort of normal phenomena happen as well. And then touch on sleep disordered breathing, and then finish on epilepsy. And I think one of the questions I get asked time and time again is, how much sleep should my child have? And I have these figures here, and because you have to tell people, but there's a huge variety of normal. And I think in the population we're talking about today, you also then have the issues of frequent seizures, you have the issue of medication, and you have the sort of sleepiness and the disrupted sleep related to both of those things as well. So it is not straightforward. One of the things that I often find helpful to illustrate to people is what I call the sleep centiles. Does this work, or is this for your computer, Ingrid? It does work. Okay. And this was a study of 500 children in Europe who were followed longitudinally to see how much sleep they have. And I think it's fascinating. This is the age here in months, so it's 1, 3, 6, 9, up to 18 months, and then up to 2 years, and from there on it's in years. And then here is the hours of sleep. So we have 19 hours of sleep, 9 hours of sleep. And so here's the midway mark, here's the people on the lowest 2 percentile, here's the people on the uppest. And you can see this enormous, large inter-individual variation. It is massive. You have some children who are having, or infants, who are having 9 to 10 hours sleep, and some children doing this. This is parental report, but over time what you find is that that individual variation drops. And so by the time you get to teenagers, we're looking at about 2 to 3 hours versus this massive spread here. And one of the things they found is also that if a child was on a certain line, they tended to follow that line. And so this is in typically developing children, but I think it's important to have a range of the huge variation that we see. The other thing I would like to highlight is the sleep development with age. And basically, when we look at sleep, bring in children for a sleep study, and we do a limited EEG so that we can work out what the sleep patterns are, we basically see that with increasing age, there's a change in the patterns of the type of sleep and the percentages of the different sleep we have. That's very important. If you look at yellow is the lightest sleep, and sometimes you might hear that referred to as non-rapid eye movement. Stage 1. And basically sleep's divided into 2 stages by the presence or absence of rapid eye movement. And rapid eye movement is the dream sleep. So if you just on these slides think red, REM sleep, dream sleep. And then the non-rapid eye movement sleep is divided up by EEG characteristics we look at. So into lighter sleep, light sleep, which is the green, and then deep sleep, which is the blue. And what you often see with children, very young babies, is that they have lots of changes during the night. Sometimes people think you fall asleep, it's a flat line, and then you wake up. And it's not like that at all. We have all changes in our EEG overnight, noting that a lot of the children we're talking about today have as well significant electrical outbursts all during the night. So as an infant, we see numerous transitions through to dream sleep, and then by the time we get to about 7 years of age, we get a more constant pattern happening with most of the deep sleep, the blue sleep, in the first few hours of night. Then we start to get dream sleep, and then generally in the second half of the night, we're looking at most of the dream sleep and lightest and light sleep. And that's important so that for a couple of reasons. If you're looking at normal childhood wakings, we all know about dreams, and often these arouse from rapid eye movement sleep. The timing of them is often in the second half of the night, as distinct to the sleepwalking and night terrors, which happen as children come out of deep sleep, and they're usually in the first few hours of sleep. And sometimes these can be quite frenetic and can be challenging to differentiate from seizures occasionally. But what's important is that the number of times children transition to different stages during the night, and the concept of how a child learns to fall asleep actually can have a significant impact on sleep duration during the night. Now, I'm not saying there are plenty of children where you'll have a particular routine where you're intimately involved in getting your child to sleep and they sleep through the night. That's not a problem. But with the children where you have to repeat that routine again and again and again, then I think that is a problem. And so what I'm talking about is this concept of how the bedtime routine is and how the child learns to fall asleep. And I think that there are some children where you develop very complex routines, whether or not it's with feeding, patting, holding, rocking. Sometimes I have families put them in the car and take them for a drive. And I think that these associations often are learned, and I think that awakings during the night are normal. All of us do it, and you tend to take what's happening and you just settle back to sleep again. But when things are very different, you don't tend to transition back to sleep. You tend to go from a normal arousal to an awaking. And if that happens repeatedly during the night, then that certainly can lead to significant issues with nighttime wakings. And I think in children with significant developmental disabilities, they have impaired communication, they have impaired ability to self-soothe and settle. And as well as that, there's a whole lot of medical problems in terms of things like spasms, pain, salivary control, skin irritations, reflux, seizures. So I think before you embark upon any sleep program as such, it's important to make sure we've eliminated as many of the medical contributing factors as possible. And I think also with this group, you have a very heightened vigilance, not only because of the seizures, but also for those children who can be unsafe at night when they're up and wandering around. And so I think it's important to look at ways that you can manage that, because I think it's very challenging otherwise to sort of work on sleep patterns. So I think what's important is that the intervention really needs to be tailored to your specific child, your family and your parenting style and the medical problems of your child. It's not one case fits everybody. One of the key things is a regular bedtime routine. And one of the things that I find often very interesting, and particularly as children get older, is people get fixated about having to have a certain time that the child's in bed. But I actually think one of the key things is, yes, the time in bed, but what time does your child actually fall asleep? We don't promote good bedtime patterns by having what I sometimes call a pretend bedtime at 7:30, but the child doesn't fall asleep till 10:30, and we spend the next 3 hours attending up, down. And so I think it's important, this concept of what I talk about, bedtime fading, looking at the time your child falls asleep regularly, making the bedtime much later, and then we can fine-tune and move it back. I think looking at the routines and patterns, making sure there's not a lot of variability. You know, I see families sometimes that can have 3-hour variations between weekdays and weekends, and it's like us flying from Melbourne to Perth to Melbourne to Perth, and that's not very good for sort of consolidating circadian rhythms and sleep patterns. And in terms of changing sleep associations, it can be done very gradually. Unfortunately, in the community, we often hear about controlled crying and people think that's all there is, but it is certainly not. I think you need to examine exactly what's happening, and then just gradually, in a supportive way, you can change things and extract yourself, change whatever the associations are in a supportive way. And I often use a camper bed as well to try and promote that overnight, because I think it's very hard to be consistent with a plan if you're up continuously and you're exhausted. And you've also got to feel comfortable with this plan, because children learn by you guys being consistent. And if you're tired or if you're unhappy with what you've been told to do, it's not going to work. The sleep schedules are important, and I talked about the time going to lights off to waking up in the morning, but the other thing is as children age, their sleep duration decreases, and so to have teenagers in bed at 7 o'clock, I appreciate why sometimes in the family you want that to happen, but if people aren't capable of 10, 12 hours sleep overnight, if you're putting someone to bed at 7, they're going to be up at 5 or 4, and so it's understanding what the circadian rhythms and needs of the child are. Sorry, Ingrid. So in terms of treatment options, I think I've talked about those. I think it's important to have a good sleep environment, a consistent one, so a child learns to fall asleep where they're going to be spending the night, and cues to define night and morning. I think it's very hard. Sometimes parents will say, it's okay for my child to come to my bed at 5 o'clock in the morning because I've nearly made it through the night. Whereas I say, well, why isn't it okay at 2 o'clock or 3 o'clock? What's the differentiation? And so cues, sometimes I find a timer with a night light coming on at a particular time in the morning to say that's the time you can start the day. Things like that can be really very helpful. And I'll talk about technology in the bedroom in a minute. I think in terms of consolidating patterns and rhythms, sunlight in the morning is incredibly important to make sure that we retrain and keep our circadian rhythm regular, and we're lucky in Australia. I want to touch on the melatonin. Melatonin, I'm sure you will have heard of, you've probably got your children on it. It is the sort of hormone of darkness. This is the night, and we get a secretion of melatonin at night, and then with sunlight it's a very powerful suppressor, and it drops and then it starts again. And so melatonin is produced in the pineal gland, and there's been a lot of work done, particularly in children with autism, looking at the production of melatonin and the receptors, and there's certainly some physiology to suggest that melatonin secretion and responsiveness is suboptimal in some children. melatonin is it's safe. It's been around since the early 90s. When you get pure melatonin, the main side effects are sedation or headache. In Australia, we've been a little bit limited because melatonin's come in as a food additive. It hasn't come in under our normal drug regulatory guidelines, and we've only actually got one PBS available melatonin called Circadian, which is a slow release preparation that came in a couple of years. And in actual fact, it's not, we can prescribe it off label, but if you look at the indications, it's for people over 60, it's not children. The compoundier pharmacies import synthetic melatonin from overseas and can make it up, but it's very expensive, as some of you will know, and I call liquid melatonin liquid gold because it is actually that expensive. And then I have a lot of families who source it from overseas as well. I think the main thing with melatonin is because it's made in the pineal gland in early days, we didn't know where it came from, and there were cases of it sort of being extract and not synthetic, and so that's why people have been very cautious about it and making sure that it is synthetic and that it's pure. I think certainly it's very effective in certain children, but time and time again, a lot of the programs show that if it's with a sort of structured and scheduled sleep routine and appropriate behavioural strategies, it's the most effective. There was a review recently in July looking at 12 randomised controlled trials with melatonin in children with a variety of developmental disabilities. And so referring to the work that Dr. Gill talked about earlier, these did have placebo arms and then they were crossed over, and definitely they all showed that there was an improvement in sleep onset of between 30 to 45 minutes. I always find that amount of improvement minimal given the amazing clinical presentation of families saying how much improved their child is. In terms of sleep duration, it's out. There are just as many trials saying yes and no. And the other thing to note is that the doses are very individual. Some people are on very low doses and can have a significant effect, and some people are on higher doses. There's no one particular dose. And the other thing is everybody focuses on melatonin as a hypnotic, that is something to fall asleep, which you give before you go to bed. But I think it also has very powerful effects on the circadian rhythm as well, and often people don't understand that with the timing of the melatonin. So I think it's important that if you use it, you give it at a regular time and you use the smallest dose possible. But I think it won't override a lot of the other things I talked about in children and how they fall asleep. People think it's going to be the magic answer, and it's often not. In terms of technology, I talked before about melatonin being the hormone of darkness and sunlight suppressing it. The most powerful suppressor is actually blue light, and blue light is a very energy efficient light that all our screens, our laptops, our phones, our iPads emit. And so one of the things I tell people is, I'm not just being difficult, it's silly to give synthetic melatonin when we're doing everything we can to suppress it. So I think look at strategies, and this is also relevant to you guys, in terms of limiting the use, seeing if you can download programs to diminish the amount of blue light or diminish the brightness, and then using devices with smaller screens. But in an ideal world, I think it's better if you are screen-free for 45 minutes before lights are off. In terms of nighttime wakings, all kids will have confusional arousals, sleepwalking and night terrors. Therefore, are more likely these events if you don't get enough sleep. And what these conditions are, because we have a different neuroanatomical pathway for sleep and a different one for awake, what happens is as you transition out of deep sleep, I describe it as being, you get stuck. Half the brain's awake, half the brain's asleep. So you have this coexisting funny condition where you're half awake, half asleep. And that's why you look like you are awake, because you seem semi-responsive, your eyes are open, but you are asleep in that you're not responding to whatever attention your parents giving you. And I think the other thing is, particularly with the night terrors, which is sort of a sudden outburst of screaming and absolutely terrified behaviour, you get activation of that flight and fight reaction. So you get the tremors and you get the shakes, you get the sweating, you get the hyperventilation. And also with the confusional arousals, which I describe as like a temper tantrum while you're asleep, these things can be quite difficult to differentiate from seizures. And that's why I go back to this diagram that I said before about the different colours and the different times of the night that they're more prevalent, because that might help you work out some of the wakings. Blue is the deep sleep, and this is generally when the sleepwalking and the night terrors and the confusional arousals happen in the first 3 to 4 hours after you are asleep. The nightmares I talked about. The other thing to note is I'll just touch on sleep disordered breathing. That is more problematic in dream sleep because you get a relative relaxation of your muscles, so you don't act out your dreams. So all the upper airway muscles relax, and Sam talked before about some of the difficulties with the muscles and oral motor coordination. And so all these issues become a lot more problematic. And so you may see your child when you go to bed about here and their breathing seems fine, but it may not be until more periods of dream sleep happen that the really what's happening with your child asleep and breathing is apparent. And seizures generally have a predisposition for non-REM 1 and 2, that yellow and green. So they can happen all through the night. But just to think about the other sleep phenomenon, it might help you work out what's happening in your child. In terms of obstructive sleep apnea, what tends to happen, and this is simplistic, there are lots of other things that happen, but if you do a cross-section here and look sideways, there's your child's airway, there's the tongue, there's the tonsils, which is the lymphoid tissue at the back of the throat, and adenoids at the lymphoid tissue at the back of the nose. When you're awake, you have all these muscles holding everything open and you can breathe okay. When you fall asleep, and particularly during that REM sleep, that dream sleep in the second half of the night, you get a relaxation of those supporting airway muscles, and as well as that you get plenty of other changes with your breathing overnight, and you can get a collapsing of the airway. And this is what we mean by obstructive sleep apnea. You get repeated episodes, and in kids it's usually partial obstruction, it's not complete, and that causes sleep disruption and problems with your breathing. How do you know your child has obstructive sleep apnea? Sometimes it's obvious, sometimes it's not. I think noisy breathing, snoring, think about it. If your child seems to be very laboured when they're breathing at night, so if you've had children who've had asthma and chest muscles sucking in and out, that sort of breathing. If you actually hear any pauses or choking or gasping, and it's tricky because if you have a noisy child, we all do have normal pauses in our breathing, and sometimes that is what you can be hearing. But I think these sort of things are at least should I have my child evaluated? Often they're restless, and it's tricky in this group of kids because the daytime sleepiness, is it because of seizures overnight? Is it because of the anti-epileptic medication? But I think it's something that if you have significant obstructive sleep apnea, it makes your epilepsy worse. And sometimes I've certainly seen kids who've been quite stable and then their epilepsy's gone off, and it's not been until much later that the pennies dropped that, they've developed obstructive sleep apnea, and that's what's happened. If we're not clear, sometimes we need to do some tests, and the two most common tests would be a machine called an oximeter that you can take home. No mean challenge, but it certainly can be done, and that measures oxygen levels and heart rates, and it's a test you can do at home, and there are particular patterns. If it's normal though, it doesn't help us, and sometimes then we need to go on to a sleep study, which involves more intense monitoring and a trip in hospital looking at things related to sleep and breathing. Treatment for significant obstructive sleep apnea generally would be removal of tonsils and adenoids, but there are conservative treatments that we can try. Often nasal steroids can be very effective to reduce the size of the adenoids and open up the airway. There are some children who need to go on to machines to help them breathe at night. Obviously, in this group, that's tricky, but it can be done. But I think it's important to think about it, particularly if you have a child who has noisy breathing or a history of tonsillitis or lots of ear infections. And in terms of the epilepsy, I think epilepsy and sleep have a very complex reciprocal relationship, to say the least, and you could spend hours talking about what does what. I think in the sleep side of things, any insufficient sleep with the things we talked about before, sleep disorders such as the obstructive sleep apnea, the night terrors, the confusional arousals impact upon a child's maintenance of sleep and sleep quality. We then have the seizure activity during the night. We have the anti-epileptic medications, some of which help you fall asleep, a couple that make it actually much worse, and then often the side effects of increasing weight gain, which again can affect the breathing, and then the sleep fragmentation that is continually documented even when you have stable epilepsy, that can sometimes lead to poor quality sleep. So I think they are definite bedfellows, and you have to have an understanding of both. The seizures, I think you have to have good control for good sleep, and I think it's tricky when you suddenly start waking. You really need to try and tease out what it is that's causing it. The parasomnias, the night terrors and the confusional arousals that I talk about, that when you've got that tremendous activation, that flight and fight and sort of shaking, and it's very hard to know what's happening. And I think making sure there's nothing interfering with the quality of sleep, such as obstructive sleep apnea. And then the role of the anti-epileptic medications. So it's not straightforward, but it is complex. I think in terms of resources for you guys, there's hundreds, if not thousands, of books on how to solve your child's sleep problem in typically developing children. There are very few that are in children with developmental disabilities. I actually think this is one of the best. It's written by a group in the US, and Beth Marlowe has a huge range of experience with children with autism. And it's actually written in a very nice way. It's not specifically for epilepsy, but it just has some nice strategies. You can buy it on Amazon for $18, and it's actually, I think, of all the books out there, probably the best. So I will leave it at that. Am I over? Yes, Dave.
Okay, so as my team run around for the questions, please put up your hand. We have one over there. Thank you, Margot. That was wonderful. I'm just going to ask you, there are two on here. The first one is, can prolonged use of melatonin be harmful?
Sorry?
Can prolonged use of melatonin be harmful?
Yes, the million-dollar question. We don't know what it does long term. In animal experiments, there's a theoretical risk of precocious puberty, and in the very early days there was one paper that looked at an exacerbation of epilepsy when you had complex epileptic syndromes with multiple medications that has never been replicated. So at the moment there's and growth, at the moment there's not much data out there.
Okay, at the back there.
Hi, my son's seizures are mostly nocturnal, so this is very interesting for me. Do you do sleep studies for children with nocturnal seizures?
We do them. If I get a hint that it's seizures, I would tend to defer to the epileptologist. But sometimes you see children where it's not clear what's happening, and a sleep study is quite a good place to start. But if you're looking for actual seizures and foci and things, they do a more extensive prolonged EEG monitoring than we do.
Oh, okay. All right, thank you.
Jen, just across to the next lady there. Yes.
Hello. My daughter falls asleep quite well with melatonin, but then she wakes frequently during the night. She also has seizures at night as well. But would it be worth a trial of the slow-release melatonin? It doesn't seem to be talked about as much as the other one. But
yeah, look, you can try the slow release. The main problem with the circadian is you need to take it as a tablet. So if you crush it up, it turns into the short-acting. So you could certainly try it. It's just mainly how you get it in.
So if she won't take tablets, it's
Yes,
tricky.
I know. That's the problem with it. Because
makes
once you
sense,
start
yeah.
crushing it up, it's not slow release anymore.
Leslie.
Yeah, hi. Our daughter actually has the opposite problem where she sleeps far too much.
Yes.
And it's interesting listening to what you're saying because we've never sort of thought that it might be another problem other than the seizures that are making her tired.
There are primary sleep disorders which are associated with excessive amounts of sleep, and I didn't touch on them today. Sometimes the excessive sleepiness is medication related, or it could be unrecognised seizures or something happening during the night. But if it's impacting upon her daytime functioning, she's falling asleep in unusual situations, then she needs to be seen.
I'll just add a little epilepsy comment there. I know that 2 of the parents who've spoken have got children with Lennox-Gastaut syndrome. Lennox-Gastaut syndrome children and adults have tonic seizures in sleep. And the more you monitor them, the more you find. And you don't know about at least half of them, if not, you know, about 10% of them. So that's the problem. They're exhausted because they're having seizures all night. And that's why they're on many drugs. And that's a very hard thing. So it could be primary, but I also know that Lennox-Gastaut is about as hard as it gets for sleep. There's one at the back.
Hello. My son has sleep apnea. We're still looking into it at the moment. But we've just noticed that when he wakes up, he's very shaky and he actually struggles. He's 16 months old. He's been walking for 2 months, but he really struggles in the morning because he's much less stable and very shaky. Do you know what could be causing that?
Yeah, when you have obstructive sleep apnea, often you have quite significant work of breathing overnight. You use quite a lot of energy, and depending also on the sort of quality of the sleep and how frequently stopping breathing happens, the sleep is not restorative. It's like kids are going for a run every night. So I think there can be several things that can lead to just not waking up and being, you know, chipper in the morning, and that certainly could be one of them.
I know there's one over there, but there's one online I want to just ask for Michelle from Australia. Any suggestions for improving sleep for someone with cortical visual impairment who may not process light and dark like we do?
Yeah, and I think that's where melatonin definitely has a role. And the problem is if you don't get the visual cues, you can get this very free-running pattern. So I think the other things that control our circadian rhythm, such as meals and food and such as physical activity, really need to be accentuated in people who have impaired light. And a definite dose of melatonin, not used as a hypnotic, but more as a circadian entrainment, so a much smaller dose, several hours before you go to bed.
I'm letting us go over time because I think this is extremely important. There are 2 more that we'll have. Gentleman over there.
I just have a question in regards to the melatonin. You said that there's a gland in the body that creates it naturally. If you're on melatonin long term, will that cause the body to stop creating melatonin itself?
No one can answer that. It's produced in our pineal gland. This is talked about every single sleep meeting I go to, and no one has an answer. And the assays of melatonin at the moment, you can do it in urine and saliva and blood. We don't know that. I don't think it does. You know, it's not like you have synthetic melatonin for so long and you won't produce it yourself. I think there are many other things that keep our bodies entrained, but no one knows the answer to that.
What would be the maximum recommended time to stay on it?
I don't think you can answer that one either. The way I tend to work on it is if it helps some children trying to find the minimum dose and sometimes having holidays from it. But again, it's weighing up the pros and cons. And if you really have a child who seems to have significant sleep problems off it and then on it they improve so much and improves their daytime functioning, their learning, their behaviour, a whole lot of things, it's like any medication, you have to sort of weigh up the pros and cons.
Okay, last question.
I think you've almost answered it. Melatonin works for my daughter, finally, but my question was, should we at any stage try and take her off it to see if those problems have sort of fixed themselves as such?
Yeah, and look, I definitely do. Particularly, I look after a lot of children with autism, and sometimes these problems do wax and wane over time, and sleep does sort of beget sleep. Once you sort of improve routines, get more sleep, I then, when things are stable, not necessarily during school term or towards the end, I wean it down and see what happens, and I wean down slowly as well. So I think it's worth giving it a go because it does change. And the other thing is it changes for good, but also changes for bad. And so sometimes you need something else when things go bad. And so that's why I also try and work out, do we need to still be on it and what's the minimum dose?
Well, I think you can see why she's the best. Practical, how to make it work. Thank you very much. Please help me. Thanks.